All right, it is noon, so we are going to get started, and I want to thank you all for joining us today. My name is Vanessa Carson Sasso, and I am the treasurer for the National Alliance for HIV Education and Workforce Development, or NAHU, and also the co-investigator for this ORN project that NAHU has. And joining me today is Liz Lazo, NAHU's secretary and project manager for our ORN project. Today's webinar, Treating HIV at the Intersection of Substance Use Disorder and Homelessness, is the sixth session in a 7-part webinar series, Bridging HIV, HCV, and SUD Innovations in the Field, hosted by NAHU in partnership with the AIDS Education and Training Centers program and the Opioid Response Network, or ORN. The session today is recorded, and we will make the slides available and the recording available within about a week on NAHU's website. Next slide, please. So NAHU is a membership organization of the AIDS Education and Training Centers program, and we support the AETC mission. We were established in 2010, and for folks that don't know, the AETC program is a HRSA-funded program through the Ryan White program. Essentially, we're the training arm of the Ryan White HIV/AIDS program. And next slide, Liz. So since 2018, NAHU has been part of the Opioid Response Network, or ORN, which is funded by SAMHSA to the American Academy of Addiction Psychiatry. And we are a partner organization. There's about 50 of us. And we are the only TA provider partner in the ORN network, specifically providing TA around HIV. So we are very excited to be part of this collaboration, and ORN was created to support efforts in addressing and prevention, treatment, and recovery of opioid use disorder. And ORN provides free technical assistance. So if you're not familiar, you can click on the link here on the slide to get familiar or to go ahead and request technical assistance. So today's webinar, we are offering credit. We are offering CME, CNE, social work, and certificates of attendance. In order to receive any of those, we ask that you please complete an evaluation within 2 weeks of the webinar today. But of course, even if you aren't looking for credits or a certificate, we do ask you to please still complete that evaluation, because your feedback is so valuable to us, and it will inform additional webinars and additional TA that we provide. So please do that. And Liz will drop the link to the evaluation in the chat later on in the session. And certificates will be mailed to you within 2 weeks of you completing the evaluation. So please do. But regardless, like I said, please, please, please complete that evaluation. So without further ado, I have the pleasure of introducing our speaker. So Dr. Jennifer Brody provides HIV primary care and addictions care at Boston Healthcare for the Homeless program. She is also the director of Boston Healthcare for the Homeless program's HIV program, which provides comprehensive healthcare and outreach services to approximately 330 of Boston's most vulnerable and homeless people living with HIV. In this role, she oversees program planning, implementation, evaluation, and quality improvement activities at BHCHP, with the goal to eliminate inequities in HIV outcomes for this population. Dr. Brody is an instructor of medicine at the Harvard Medical School and co-leads a social justice curriculum for the Division of General Medicine Primary Care Residency Program at the Brigham and Women's Hospital. She teaches medical residents, public health students, and physician colleagues in a variety of forums about the special healthcare delivery needs of people experiencing homelessness using a racial justice framework. And we are just so pleased to have Dr. Brody here today presenting to you all. And we will save questions to the end. So please use the Q&A feature in Zoom to drop your questions in, and we will hopefully have enough time to address all of them at the end of today's session. So I will now turn it over to Dr. Brody. Thank you so much.
Thank you so much, Vanessa, for that introduction, and to everyone who's joining. Been noticing the chat people all over the country, so it's really an honor to speak with you and to have this opportunity to share some of our work from Boston Healthcare for the Homeless program and some of our early lessons. So these are our learning objectives for our session today. I'm not going to read them, but you can refer back to them in the slides. I want to start off actually with a patient case. I am a HIV primary care physician in addition to my administrative roles, and our work is really rooted in individual people and their lives. And so this is a case of Miss M. She's a Spanish-speaking woman from Puerto Rico with severe opioid use disorder and chronic mental illness. She was never had seen a psychiatrist and never had a clear diagnosis. She's had multiple non-fatal opioid overdoses and has been living unsheltered, or really on the streets in Boston for the past 12 years. She was diagnosed with HIV earlier this year. Ms. M has worked with various housing case managers over the past 5 years, and she's been barred in the past from multiple women's shelters and now actually refuses to access them. Her top priority at every single visit with me as her HIV primary care physician is housing. So with that case in mind, I'm going to share with you a little bit about our program. So Boston Healthcare for the Homeless program has been delivering care since 1985. We were founded 36 years ago by the Robert Wood Johnson Foundation and the Pew Charitable Trusts. We have very strong partnerships with the Boston medical community, homeless service organizations, housing organizations, and city and state government. And so the work that I'm about to describe is really in partnership with many other agencies citywide. Our agency provides care to approximately 11,000 homeless adults and children annually, just to share with you some of the scope of our work. And our HIV program is best described as a multidisciplinary primary care program for approximately 330 people living with HIV who are also experiencing homelessness or unstable housing in the greater Boston area. And we are funded, most of our work is funded by the Ryan White programs Part A and C, as well as through the Massachusetts Department of Public Health through Part B funding and other funding sources, as well as through the Ending the HIV Epidemic funding streams. Some of the interventions I'm going to share are funded by other federal entities, including SAMHSA, as well as some foundations and private sources. And so if folks are interested in learning those details later, you'll have my email information and can certainly contact me about those details. And now I'm going to turn just to describing the patients, the people that we take care of, and just start with some demographics about our patients. So our overall HIV program cohort is overwhelmingly people of color, 77% people of color, 40% identify as Black or African American, 37% Latinx, and 20% non-Latinx white. Almost a quarter are monolingual Spanish speakers. The majority are men at 70%, a quarter women, and 5% people are of transgender experience. Excuse me. The most common mode of transmission in our cohort is injection drug use, with half of our cohort identifying that as the mode in which they contracted HIV. Many, 84%, have prior active substance use disorder. Almost half have an active opiate use disorder, with an additional 10% describing an active methamphetamine use disorder. So this is a very, very common experience among our patients living with HIV. 3/4 have a diagnosed mental illness. This number, of people who are actually living with mental illness is much higher. I think this is just folks with an actual diagnosis on their problem list. And unfortunately, many of our patients have the experience of being in the criminal legal system, and have had 1 in 10 have had an incarceration of 30 days or longer just in the last year. And all of our patients are homeless experienced. 39% are literally homeless or unstably housed, and 61% are stably housed overall. I'm going to spend a lot of my time today talking about the cluster of new HIV cases in Boston, which has really pushed us to radically readjust and redesign our program. The image there that I've showed is a really powerful picture, I think, of taken by the Boston Globe. We Out Here was spray painted on the steps of the Syringe Services Program, which is right next door to us, which I think speaks so powerfully to the marginalization and the invisibilization of the population I'm about to describe to you. So let me tell you a little bit about the cluster of cases, this new outbreak of HIV cases in Boston. So starting in about November 2018, we began to see a rise in HIV among homeless people who were injecting drugs in Boston. And to date, our program, Boston Healthcare for the Homeless program, has linked 91 of those new cases. So folks who are injecting substances and experiencing homelessness so 91 of those people have been linked to us since 2018. And these are folks who are diagnosed not through traditional screening programs and not through primary care programs, but rather mostly through hospital admissions for drug-related healthcare issues. This wasn't a group that was really necessarily very well engaged in kind of routine medical care and not well engaged with the medical system overall. And when we look at the HIV cluster demographics, again, this is the Boston data from I'm going to share a little bit of what we know from from data shared by the Boston Public Health Commission and the Department of Public Health in Massachusetts as of March 2021. But they describe that there's near universal hepatitis C exposure, major mental illness, as I've already described, patterns of kind of poor healthcare engagement of folks who are newly diagnosed, high rates of recent or current incarceration, and the drugs used included both opioids and methamphetamines. And the overall number that has been published by our State Department of Public Health was well over 100, and that is a growing number. What I can speak to, I think with the greatest degree of knowledge is the group, the subpopulation of those folks who are linked to our program. So it's 91 people so far, and all of them have active substance use disorder, major mental illness, and unsheltered homelessness. So these are folks who are primarily staying on the streets. We're seeing greater numbers of women who are newly diagnosed at 38% compared with the 25% that I showed you for our overall cohort. Very high rates of recent incarceration, and a higher percentage of people who are identifying as non-Latinx white in terms of race ethnicity at 68%. 12% of the folks that we're caring for identify as Black, and 16% are Latinx. And this group seems to be younger than our general cohort, with majority of ages ranging from 20 to 44. To say more about our local context, so this outbreak is occurring at the epicenter also of the addiction and overdose crisis in Boston, perhaps not surprisingly. And that has now included a large encampment of people who inject drugs. And this is a photograph of that encampment from the WBUR website, which is one of the public radio stations. But you can see, this is actually on a pretty, not as crowded day as it can be, but tents are lining both sides of this street. And this street is located near one of our jail facilities, area shelter, and an engagement center where people are able to come and access services in a low threshold fashion. I'll talk more about that. As our population of people living with HIV who are experiencing homelessness has become not only larger, but also is growing more and more vulnerable because of the ways in which they're experiencing overlapping systems of oppression, we have really been pushed as a program to rethink really completely how we provide care to this group of people. And really have been pushed to think about how a program designs care for the most vulnerable person on the team or group of people, patients on the team, versus designing a system of care for sort of the patient that's more stable or the stabler patients on the team. And we've found this this framework, the design for the margins framework, incredibly helpful as we've been redesigning really in an iterative and ongoing way our care delivery system. So I'm just going to share a quote from Caesar McDowell, who's at the Massachusetts Institute of Technology and formerly at the Interaction Institute for Social Change. And I think this quote just so beautifully captures this framework. So what he says is, what we tend to do in this world is design for the middle and forget about the margins. Actually, it's in the margins that we have to concentrate our design. If you pay attention to the margin and design for them, you cover the middle, like a tent. The further out you stake it, the stronger the structure you get. Why is that? Because people at the margins are living with the failures of the systems. So when we design to take care of them, we build stronger systems for everyone. So as our program really embraced this concept of design for the margins, we had to also ask ourselves, why are people on the margins to begin with? What are the policies, the structures, the systems that are in place that push people to the margins? Because you can't design for the margins if you don't understand how people got there and are kept there. And so really our program has embraced fully, or working to embrace fully, a social justice and racial justice framework. And as an agency that is working with people experiencing homelessness, a really important place for us to start was to better understand how structural racism and other systems of oppression specifically impact housing insecurity. And so I'm going to spend a little bit of time just talking about structural racism and its impact on housing for a bit. So what we know about homelessness is that it is caused by historical and structural oppression, discrimination in housing, healthcare, voting, employment, the criminal legal system, and elsewhere. And that these root causes have led to systematic economic disadvantages. We know longstanding discrimination has limited wealth production amongst Black Americans and other people of color, which has led to Black Americans being vastly overrepresented in the homeless population. Black Americans are 41% of homeless people, but only 13% of the general population. And one really important policy among many is policies around access to home loans. And this is a residential securities map of Boston, so the city that I'm working in, living in circa 1938. It's a famous or infamous redlining map that essentially looked at a city and looked at areas that were deemed high risk for mortgages. And areas that had higher numbers of people of color were deemed high risk and were not offered home loans, which are the basis for wealth building. And so when we look at the next series of images, which I'm about to show you, we can see the profound imprint that just this one particular policy has had moving forward on a whole range of health outcomes and vulnerabilities that I'm going to outline. And this could really be, certainly a talk all to itself, but it's important to mention here. So when we look at Boston in particular, and we look at how HIV is distributed, where it concentrates in Boston, we can see this is a map from AIDSview, where these are neighborhoods in Boston. And it's showing you rates of HIV where the darker red colors have the highest rates of HIV. And these are rates per 100,000. So you can see this kind of in this crescent kind of pattern, darker red here, higher rates of HIV. And if we look at other areas, other maps, this subsequent map, this map shows majority racial and ethnic group by census tract. So if we sort of look at these side by side, the peach areas are areas that are majority Black. The blue areas are majority white. The yellow areas don't have one race ethnicity as being dominant. So these are mixed population, mixed race ethnicity areas. And then the green is majority Latinx. So you can see in this crescent pattern, the areas that are where mostly where higher rates of Black Americans or Black folks are living, there are higher rates of HIV that track with that. If I showed you a map of home foreclosure petitions from 2016, you'll see a similar pattern where the darker colors show higher rates of home foreclosures, lighter colors, fewer home foreclosures. this similar pattern in this crescent sort of shape. And for us in Boston, those neighborhoods include Roxbury, Dorchester, Mattapan, and similar patterns. And if we looked at jail admissions by home address, where these red dots represent the addresses of individuals admitted to jail, similar pattern. I could show you maps for income, high school graduation rates, receipt of food stamps, and there is a similar pattern that is very profound. And if we look closely, if we return to that map that I showed you, the residential securities map from 1938, the areas that were redlined are these same areas that are still experiencing higher rates of HIV, are segregated by race, experience higher rates of home foreclosures and jail admissions. So if we look at the prevalence of homelessness among people living with HIV, half of people living with HIV have a lifetime risk of housing instability, which is still, every time I read that statistic, I'm still stunned. It's astronomically high. 9% of people living with HIV in the US were homeless just in 2017. A third of US veterans with HIV experienced homelessness, and more than half of individuals recently released from incarcerated settings were homeless. So I think it's incredibly important to say that the interlocking and mutually reinforcing structural vulnerabilities that predispose someone to contracting HIV are the very same as those that predispose someone to experiencing homelessness. Structural racism, poverty, gender and sexuality-based discrimination, incarceration, trauma, mental illness, substance use disorder, and related stigma, as well as other forms of systemic exclusion, other forms of systemic exclusion. I'm going to transition us now to talking about how we took those core principles, centering health equity and racial justice, and use that to inform designing our programs for the margins for those made most vulnerable by these overlapping forms of systemic oppression that I just described. So part of what we knew we had to do with our services is to ensure that they were non-judgmental and that they were non-contingent, that they weren't dependent on anyone agreeing to any particular kind of care. People did not have to go anywhere into an institutional setting. They didn't have to agree to see a mental health provider. They didn't even, they didn't have to agree to see a medical provider. We just kept trying to reach out and build rapport and understand what their needs were. We also knew that we had to center survival needs, that people who are experiencing unsheltered homelessness, they had overwhelming needs just to survive the day, and those really did have to be centered. We wanted to center patient choice and autonomy, and we aimed to promote harm reduction and social connection. And we knew we had to locate our care where people needed it. We couldn't continue to provide care only within the walls of the clinic. We had to begin to build our services outside the walls of the clinic. And really that meant we had to rapidly grow our outreach capacity to build really an entire team, a multidisciplinary team outside of that familiar setting of the clinic. And so over time, our program has begun to look more like this, where we wrap around an individual experiencing unsheltered homelessness, living with HIV. We wrap around case management services. We wrap around low threshold mental health care. We wrap around low threshold HIV primary care, outreach nursing with the capacity to bring someone their medications for HIV. We wrap around harm reduction services, intensive outreach social work, and we've begun to also integrate housing advocacy much more intensively in the outreach setting. What we've also been able to do through our funding sources, especially the Ending the HIV Epidemic funding, is to also begin to really focus on those survival needs of our patients, which has been really core to establishing rapport. So what we've been able to do is actually provide people food, providing people, a snack, food incentives to with their directly observed therapy. We've been able to provide people transportation, whether that's to to a social service appointment, a housing appointment, but to actually be able to get people to where they needed to go. We were able to provide people also with low-cost mobile phones. It's very hard to keep in touch with people who are unsheltered if they don't have a telephone. So we were able to provide all of that. And we were also able to provide through these outreach services, particularly the work of our nurses and case managers, intensive accompaniment and advocacy. People were moving between highly stigmatizing systems of care that they had really been mistreated by in the past. And they were not willing, for very good reason, to return to some of those systems, right? They were having to go to court to go to, to access benefits, going into institutional settings that had really been quite stigmatizing and discriminatory towards them. So to have someone to actually be with them, to accompany them, to advocate for them as they move through was really, really critical. And we think what we've been able to do with all of this is to really give people a sense that they're not alone in this, to rebuild trust, to re-engage them, and to move forward in their HIV care. So as I said, we've really had to build this outreach capacity. And what that's looked like in terms of staffing is we've brought on 2 now full-time outreach nurse case managers. And this is so that we can conduct street-based engagement, which includes medical triage, but also directly observed therapy for HIV, for their HIV medications. And that is now 5 days a week that we're able to do that out of 7. So on that Friday, they'll give someone 3 doses to get through to the following Monday. We've also embedded HIV medical providers in low threshold settings. So for example, I and several other medical providers have a clinic, so to speak, that is at one of our engagement centers, which is a tent-like structure. It's in that encampment, right alongside the encampment that I showed you a photograph of. So we provide our services right there, and we can do walks through the encampments and see people for their HIV primary care that way. If they're unable or unwilling or just don't have any interest in walking into a clinic for medical care and for HIV primary care. We've also added outreach medical case management. We have 1 full-time person doing that now, and we are hiring a second. This has been so critical to engaging this population, to connecting people with housing opportunities, resolving their legal issues, and connecting with other social services. And that's in addition to clinic-based case management that we've had for several years now, who can do outreach, but not as high intensity. And then finally, we've really leveraged our program that's funded by the Department of Public Health at the state level. It's called the Active Retention and Care in Health, or the ARCH program. And that's staffed by 2 full-time outreach social workers who are able to impanel patients, up to approximately 10 patients each, for deep, intensive accompaniment and case management to help them stabilize. And finally, we've been able to integrate outreach-based psychiatry, as well as 1 psychiatrist and a behavioral health clinician to help provide services in the field. Given what I shared with you, that almost all of the folks who were newly diagnosed with HIV have a major mental illness, this was absolutely crucial. Finally, we've also really expanded our low barrier addiction treatment. We've been able to expand capacity for same-day buprenorphine inductions for people with opiate use disorder in the outreach setting. We've really, for the past several years now, really been working with HIV team providers to make sure all of those providers are buprenorphine waivered. 4 of our medical providers are board certified in addiction medicine. And we've had our nurses, all of our HIV team nurses, cross-trained to support buprenorphine inductions and follow-up care. And finally, we've really partnered with the academic medical center that's closest to us, Boston Medical Center, with their Faster Paths clinic, which is a low threshold addiction treatment program, and they're able to provide same-day methadone initiation, which has been absolutely crucial in this setting for a lot of people who have severe opioid use disorder. And because of fentanyl and the pharmacokinetics, the way that fentanyl kind of works, that a lot of people were not doing well with buprenorphine and really did need methadone, and were more interested in being on methadone for their opioid use disorder. And previous to this program, it would take weeks to get people into methadone programming. And so this has been a really important partnership for us. We've also worked to integrate harm reduction and those directly observed treatment services. And so our program has harm reduction nurses in the encampments and in that engagement center tent space to do overdose response, to provide medical triage and wound care. And over the past year, we've developed the capacity for those nurses who've long been doing harm reduction services in that area. They also now do 7-day-a-week directly observed therapy for people living with HIV. We also do it for PrEP as well as non-occupational post-exposure prophylaxis for HIV. The overdose response, which I mentioned, is in partnership with the Boston Public Health Commission staff as well. And other interventions that we've developed include providing naloxone at our on-site pharmacy and by standing order. A lot of our outreach workers have Narcan on hand or naloxone, intranasal naloxone on hand. We've installed motion detectors in our bathrooms to prevent fatal overdoses, and we also have a walk-in sedation unit for people who are under the influence of sedating substances at our main clinical site on 780 Albany Street, which is just a few blocks from the engagement center that I showed you a photograph of. We've also included reentry case management. I shared with you the data around that 1 in 10 of our patients has had a recent incarceration of at least 30 days. So this was really key to engaging people and retaining them in care when they went in and out of jail settings. And really, really important that we don't lose follow-up, for not losing follow-up upon release from jail. And the aim of that reentry case management is to really provide tailored intensive case management for people with a recent incarceration and to maintain relationships and coordination of care during the incarceration. We know from multiple studies, and really the data is just overwhelming at this point, that housing is core to HIV treatment. There have been multiple research studies at this point, including 2 randomized controlled trials that have shown that the provision of housing to people living with HIV improves the likelihood of receiving and adhering to HIV therapy, improves HIV-specific health outcomes like helping people retain their CD4 counts, less opportunistic infections, more HIV viral suppression, and better survival, less emergency room visits and hospitalizations. It costs less, and it can lead to reduction in high-risk sexual and drug use behavior. So really powerful impacts of housing on HIV outcomes. That really pushed our program to better integrate housing services. So we, several years ago, this is before the COVID pandemic, were able to have a housing clinic on site at our main clinical site that invited existing partner agencies to actually do housing search and advocacy on site once a week with us, so that our patients didn't have to go to another agency, which sometimes they were reluctant to do for a variety of reasons, including transportation barriers and also just fear of stigma or discrimination. And being able to provide those services in a place where people felt more comfortable and where there was trust and rapport established was really, really key. We were able to complete housing applications and do housing histories on site. And then our case managers could kind of take on over all of the follow-up work that was left after the initial housing visit. More recently, we've embedded with our partners at AIDS Action Committee, we've embedded a housing advocate who's also doing outreach embedded with our housing, with our HIV teams. And we've remained in very close collaboration with multiple housing providers to really advocate for our patients to get access to any housing opportunities. So I'm going to shift now to talk a little bit about outcomes. is how effective is all of this that we're doing. Overall, so this is for our overall cohort, all 330 patients, 94 of our folks are prescribed antiretroviral therapy, 93% are retained in care, and we have an overall viral load suppression of about 86%. How does that compare? How do we compare with other Ryan White programs nationally? So if we look at the Ryan White program with this yellow bar here, stably housed folks in the Ryan White program, again, nationally, there's about an 87.2% viral load suppression rate. Stably housed folks in our program, the viral load suppression rate is 91%. For unstably housed people in the Ryan White program, 71% virologic suppression. So there's a significant equity gap here. In our program for unstably housed people, our viral load suppression rate is 83%. So I think overall, we also still struggle to close this equity gap between stably housed and unstably housed folks. But overall, compared to Ryan White programs nationally, I think we're doing okay, but we could all improve, I think. When I show you, now what I'm going to show you is key outcomes for specifically for unsheltered people with HIV who are actively injecting substances, including that cluster of new cases, those 91 people that are linked with our program. So overall, we've linked 84% of cluster patients. We've retained 93% of those. Viral suppression overall for those 91 people who have touched our program at some time is 60%. When we add in directly observed therapy of any kind, it's 26 people, the virologic suppression rate is 62%. When we look at a subgroup of that population, these are folks who are only accessing care from our harm reduction nurses through 7-day-a-week DOT out of an encampment. So that's 13 people. The viral suppression rate is 46%. When we add to that directly observed therapy with extended outreach, this is that outreach team, that circle that I showed you of the nurses and the case managers and the therapists and all of that, those wraparound supports, plus the team going out and finding people, we can get viral load suppression rates to 77%. And I also just want to highlight this, getting half of the people who are unsheltered and living in an encampment and otherwise completely disconnected from other services. This number maybe at first glance looks low, but I think when we take into consideration that folks would probably not even be offered HIV therapy, I think of this as actually a success and an important victory. Certainly we can do better, but it's a great first start. And then other key outcomes I think are really important to mention. That, what are the housing outcomes? So far, and this is a rapidly changing number, it's probably out of date already, 18 people have obtained housing since their diagnosis. Boston's currently in a big push to house this group of people that are living in the encampment. So we're seeing people getting housed really rapidly, which is exactly what we want to be seeing. And then unfortunately, I think the, overdose death is if I were to guess, I don't have this data on hand, but if I were to guess, overdose death would be the leading cause of death in this group. And we've unfortunately lost 2 people to overdose death since HIV diagnosis, just since 2018. When we return to our patient case that I started with in the very beginning. So Miss M was connected to a bilingual, bicultural outreach social worker. So there was really important language concordance and cultural concordance after weeks of engagement attempts and weeks. And sometimes it looked like walking alongside her as she cursed at us. We were able to build a relationship and reestablish trust. And she did agree to start HIV therapy. She actually remains on HIV therapy today. She's virally suppressed. We initially started her with daily directly observed therapy. Initially, she really struggled to stay on buprenorphine for opioid use disorder. It was offered to her very early on in our interactions, but because she was unsheltered and on the street, her medication, her buprenorphine, kept getting stolen, which is very, very common. And so it was really hard for her to stay on. And she didn't want to be on methadone because she found it to be the rules were too rigid and strict for her to be able to manage. And the setting was very stigmatizing for her. And so she declined to go onto methadone. After over 12 years of unsheltered homelessness, she finally obtained low threshold housing in a single resident occupancy unit just last month, which was enormously rewarding to see her finally get into housing. And the amount of all that she's been able to achieve really since she's become housed has been really quite amazing to watch. So she's now able to come into the clinic weekly for buprenorphine related visits and prescriptions. She's currently managing her HIV therapy without much adherence support at all, other than monthly check-ins. So it's been quite amazing, but it shouldn't have taken 12 years to get her housed. Some lessons learned for us: the principle of design for the margins, rooted in racial and social justice, I think can inspire important transformations in HIV programs to improve care for patients made most vulnerable by oppressive systems, which really improves care for all patients. The data that I shared with you, our housed patients aren't doing worse because we're spending a lot of time building systems of care for unsheltered homeless folks who are, with severe substance use disorder or severe mental illness. They're actually, I think, benefiting from the ways in which we're providing care and are, continue to do better overall than other, when we compare our outcomes to the Ryan White program. Understanding and addressing structural barriers and survival needs is absolutely critical. For us, we really needed street-based multidisciplinary services. We found accompaniment and advocacy roles critical to negotiating highly stigmatized systems. The first thing that we had to do was build trust, and without trust, none of this care is possible. HIV viral suppression for unsheltered people who inject drugs can be achieved. We have a 77% viral load suppression rate for people who are getting daily DOT with extended outreach, but it's insufficient in supporting the holistic well-being and long-term health of our patients. It's not all about viral load suppression. And yes, I'm an HIV primary care physician, and I said that. We have to also think about the holistic well-being and long-term health of our patients. And so in order to really do that, we need housing. Housing is critical, and there's just no medical intervention alone that's going to be enough. For us, scalability and sustainability are also issues that we're currently struggling with and trying to figure out. And finally, ongoing challenges are manifold. A couple here include that there continues to be a lack of low threshold housing with intensive support services and the right intensive support services. For this group, we really need to be thinking about harm reduction services that are embedded in housing, and not necessarily the same support services that you would think about in a housing first program that's designed, say, for someone with chronic alcohol use disorder. We need to be thinking about very tailored support services. The ongoing criminalization of homelessness and drug use and sex work makes people more vulnerable to both contracting HIV and poor HIV and other health outcomes must be addressed. The NIMBYism, for folks who might not be familiar with that acronym, not in my backyardism, which is built on racialized stigma, has been, in my locality, has really been alive and has been preventing new housing and support services for this population in the area, and it has to be addressed with proactive community and stakeholder engagement. Communities have very real concerns that need to be addressed. And so, I think it's part of our public health systems that really need to be proactively engaging community members in these conversations. Our systems are siloed and stigmatized, all of them: housing, mental health, medical, addiction, legal, you name it. And they prevent this population from being able to engage successfully and from they prevent them from healing and getting better. All forms of medication for opioid use disorder, including methadone, really need to be made available in low threshold venues, including pharmacies and primary care settings. Sometimes I think about what we could accomplish if I could prescribe methadone to some of the people that I take care of at the encampment, and how many people we could stabilize and move out of homelessness and get on HIV therapy if we could do that, which we still cannot because of federal regulation. And another huge challenge that we're dealing with at Healthcare for the Homeless is workforce trauma and burnout. It has to be addressed through funded programs. And finally, I think this is a good point to end on, overdose prevention centers, also known as safe injection facilities or safe consumption sites, are just an absolutely core, but still missing evidence-based intervention. We finally have our first sanctioned overdose prevention center in New York City. So we're all really excited to see that happen and hope that other cities will embrace that as a really key intervention in engaging this population, reducing overdose death, reducing HIV transmission. So that's the end of my slide deck, and I'm happy to open it up for questions and discussion.
Thank you so much, Dr. Brody. Just, an amazing program. Thank you so much for sharing so many lessons learned and successes, but of course, letting us know there's still a lot of work to be done. And so really amazing presentation. Thank you so much. And I do see we have one in the Q&A pod here. Oh, and another one that just came in. So fabulous. So the first one, what is the status of safe injection sites? And I think you did cover it already, but please go ahead and reiterate that one, please.
Yeah. So New York City just, I think in the last 2 weeks, opened 2 of the first sanctioned overdose prevention centers in the country. Prior to that, there was an unsanctioned and sort of underground safe consumption facility in operation in the United States. But the status is still legally a little uncertain. In Philadelphia, Prevention Point had tried to open up an overdose prevention center and was blocked from doing so by the federal government, and so there was a lot of uncertainty about what the pathway forward was going to be. And I think, New York City should be commended for bravely opening these 2 sites. And, already I've heard accounts that they've already reversed, 15, 16 overdoses that perhaps otherwise would have been fatal. And so, I think a lot of us are watching with bated breath to see, how, what the legal sort of response is to New York City's projects, and are really, thrilled that New York City has really been at the forefront, and I certainly hope that Boston and other cities follow their lead.
Absolutely. Thank you. And I hope so too. So next we have great presentation. How is this initiative funded? I may have missed that part in your presentation. And I know you did drop a couple funders, but we'll have you review that. Thank you.
Yeah, so it's a variety of sources. Our medical case management program is largely funded through our Ryan White Part A award. We also have Ryan White Part C funding, which funds a lot of our nursing time. We have funding through the State Department of Public Health, Massachusetts Department of Public Health, which funds our outreach social worker, their salaries. It also supports some of the nursing salaries, the outreach nursing salaries. We have some Ending the HIV Epidemic funds as well that are funding a lot of the transportation, the food, the funding for the food that we're able to provide, the low cost mobile phone. So it's a variety of sources. We are also a federally qualified community health center. And so, as a provider, I can, bill people's insurance, including our state Medicaid system, for clinical visits that are billable. So there's also that funding stream. I should also mention that the Ending the HIV Epidemic also funds some of our providers' outreach time.
Wonderful, thank you. Takes the village for sure. And another question. 2 more. Okay. Hello from Portland, Oregon. What advice do you have for harm reduction outreach workers who do not have medical providers on staff when working with this population? what supplies, services, and education are most important to focus on with our limited medical training?
Yeah, that's such an important question. I mean, you all are the really crucial engagement points, and you're going to be the links to so much other care potentially. And so I think you're a harm reduction worker, embracing those harm reduction principles, of trauma-informed care. I think you asked about like equipment, and I mean, obviously having Narcan, training people in how to use intranasal naloxone if you're able to, having that on hand, I think basic dressing supplies if you can get them for wound care, even just Band-Aid. I mean, so many times I think I've been able to connect with someone around wound care, and around the basics of just helping someone keep a wound clean, giving people Band-Aids, having antibiotic ointment on hand is just such I think a powerful expression of care that could then be leveraged to connect people to other things. And so I think just knowing what your resources are in your area, if there are medical providers that are more culturally competent, that embrace more of a harm reduction framework that you trust, that you can link people to, I think is great, rather than sort of referring to, that health center over there. If you're not sure what the approach is, kind of getting to learn who the providers are that your clients trust, and making referrals directly that way. Also, I would say, trying to develop relationships with other clinic-based case managers so you can actually call over. I like to try to provide a red carpet kind of approach for people. So if you can, make warm handoffs so that someone can receive the individual at the clinical setting, I think that can be really helpful. Anything that we can do if you can accompany the person to a clinical visit or to the other, social service provider, I think that goes a long way. As I said, people are navigating so much, so much stigma. There's so much earned mistrust of various institutions. And so the degree to which you can really help people navigate that, and connect people to trusted resources and trusted providers, I think the better.
That's great. Thank you so much. And we do have a few more here. How has COVID impacted this work? Are most clients vaccinated? And was this provided during outreach?
Yeah, so COVID has impacted this work, profoundly, as it has impacted work across the country. What we saw during the COVID pandemic was that more and more people were experiencing unsheltered homelessness. Like the number of people in the encampment itself really sprung up in the context of COVID, that there was more, it seemed to be there was more severe substance use disorder, more untreated or undertreated mental illness that was, I think, worsened in the context of service disruptions and unemployment and all the things that we're seeing talked about in the media, et cetera. And so just the whole dynamic of the encampment, the rising rates of HIV, I think are related to the COVID pandemic. But in terms of our services, we actually were able to provide street-based outreach all through the pandemic. But it became challenging to get people into residential treatment programs during COVID because bed numbers were quite limited. We have a medical respite facility called the Barbara McGinnis House for people experiencing homelessness. And it was harder to get people into that setting, which can be a really important intervention for stabilizing people. But because beds were limited, we were running a COVID unit there, it was harder to get people. And so we were impacted in that way. In terms of you had asked about vaccinations, our program has had a large COVID vaccine initiative for people experiencing homelessness, including unsheltered homeless folks. And so we were able to provide COVID vaccinations in the encampment and on the streets as well. And so many of our patients are actually fully vaccinated against COVID.
That's great. Thank you. Thank you so much. And we do have a few more. Have you been using long-acting injectable HIV treatment in this population? Any tips on patient buy-in?
Great question. I think we had hoped that the long-acting injectable antiretroviral therapy, which is the one option that we have, Cabenuva, isn't quite what we thought it would be in terms of being appropriate for a patient population that was that had spotty adherence and limited capacity to do follow-up. With the long tail, as they say, it can be in the system for 12 months. We haven't been using much Cabenuva, actually no Cabenuva in this population, for concerns around loss to follow-up and lack of adherence, and what that long tail might mean for resistance. For the clinical folks on the call, part of what we're seeing in our local outbreak of HIV is some transmitted drug resistance, which actually includes real rilpivirine resistance as well, which is one of the components of the long-acting injectable antiretroviral therapy, Cabenuva. And so we haven't been using much of it really at all to date. So if others are using, I'd love to hear your experiences.
Thank you for that. Yes, and if there is anybody who wants to share their experience, please drop it in the chat or the Q&A or raise your hand. So a couple more questions here in the queue. It is a great evolution. This program includes some contact and relatives of the participants. Okay, so that's a comment. So thank you, Carlos. Appreciate that. And another, well, the last question in the queue at the moment, hello from Ryan White program in Southern West Virginia. Low barrier harm reduction has been outlawed throughout the state and criminalized here. We are in the middle of the most concerning outbreak in the US, according to CDC this year. Any suggestions? We know as a clinic that we have to provide low barrier harm reduction, but because of recent legislation, it's not an option.
Yeah, I'm in solidarity with you and the barriers and the challenging situation that you're facing in your state. It may be helpful to find out exactly which components of low threshold harm reduction are fully excluded. I'm not sure if the participant was talking about syringe service programs or intranasal naloxone, or which component was sort of no longer allowed or not allowed at all. But being clear about what the regulations are and what you can navigate, what you can do and continue to do that. I think in those situations where it really is about a policy change, joining forces with others around advocacy and like op-ed writing and writing letters to legislators and talking about what you're seeing on the ground and the public health impacts of these laws and policies. But it is the ongoing criminalization of substance use is a terrible problem that we're facing, and it really does require policy and legal change.
Thank you. And Brooke did make a couple additional comments to her question. So one-to-one exchange only, barcoded syringes, state issued valid ID are the biggest barriers.
Yeah. I am honestly speechless. It makes no public health, those policies make no public health sense in my opinion, especially for, in an area where you're facing an outbreak of HIV. Syringe service programs, the data for the public health benefits are overwhelming. It's, I think it's going to take, it sounds like, more advocacy and activism to address the legal barriers.
Thank you. Yes, it is hard to think, sometimes we're in a bit of a bubble. At least I live in Massachusetts and I do my work in New England. So thank you, Brooke, for that perspective from West Virginia. There are no other questions at the moment, and we are 1 minute away from the top of the hour. So I am going to thank everyone for joining us today. And again, just thanks so much, Dr. Brody, for your fabulous presentation. We will get the recording up and the slides up on the NAHU website shortly. Please fill out your evaluations. Liz put some resources in the chat from the AATC program. If you're not familiar with your local AATC folks, please look into us. We're here to help you. And I think that is it for today. Liz, anything else before we close?
I have also added the information for the next session. We hope that you join us the last session in this series on January 14th, and you can find that information in the chat.
Wonderful. And I do see something. Oh, okay. There was a thank you. Okay. Just want to make sure there wasn't a lingering question in the Q&A box there. But thank you again to everyone, and have an awesome weekend. Thank you so much for joining us.